for having me. This is pretty exciting for our team here to be able to participate with you all and just speak about our experience with working with and caring for gender diverse youth here at the Stanford Gender Clinic. So to start, my objectives for today. So I'm going to really provide a very brief overview of just gender terminology to kind of orient us and you all to the language that I'll be using and making sure that when I say a term that we are conceptualizing it in the same way, because there are multiple ways of interpreting different terms, especially within gender care. And also present relevant research. And what I mean by relevant is in the context of working with caregivers. There's some really powerful data and research out there that I rely on consistently, or I find myself sending to parents and caregivers pretty often. So I want you all to be aware of those and be able to use them if you find that they could be useful for the families that you might be seeing or working with. I'm also going to share with you a framework for really assessing, and what I mean by assessing is not diagnostically assessing, but like clinically assessing where a caregiver, where a caregiver might be in terms of readiness, and also assessing where caregivers' barriers might be or the roadblocks might be. And then, of course, offer you all like tangible and, usable strategies for collaborating with caregivers and specific techniques that I have found useful when working with these caregivers. And then, of course, if you all have cases to share, I'm happy to hear those and we can talk through those as a group together, or I have brought some case examples of families here in our clinic to highlight some different aspects of what I'll be talking about. So we can do either or. Disclosures. I don't have any formal disclosures, but I do personal disclosures at the beginning of every talk. So I do want to acknowledge my privilege. I am half white, half Vietnamese. I am cisgender, I'm educated, I'm now resourced, I'm able-bodied. There are other forms of privilege that I carry. So I do want to acknowledge that might come with some implicit or explicit biases. But I also acknowledge it's a super rewarding and privileged to work with the population that I do. Working with gender diverse patients and their families has been my dream, and I'm living the dream here at Stanford doing this full time. But I also recognize because of my privilege and because I'm not a member of the community, I'm coming at this with a lot of humility. And my patients are teaching me on a constant basis more about the community and how to best serve their needs. I also practice through an affirmative care model, which is what is recommended by the American Psychological Association. However, there's lots of ways to provide affirmative care. And so the way my approach and philosophy to working with these parents and families is just one of many ways that could be considered affirmative. So I do want to recognize, if what I'm recommending for you all today may or may not work in your context or may not work for you personally. And so, you might have to adapt or trial and error, or use other techniques. That my way is not the only way. And I just want to be sure to allow for kind of an openness of different approaches. I also integrate a trauma-informed approach to my work, especially when dealing with difficult caregivers or families. And trauma-informed care is just a model of thinking about what the person in front of you has maybe been through, what adversities they come into the room with that has created potentially difficult behaviors or maladaptive behaviors or frustrating behaviors, and checking in with myself regarding my frustration with somebody and kind of framing that person in a more positive light to be able to continue to engage with difficult families at times. So I'll be highlighting that throughout this discussion. And then working with this population is not for everyone. So we do have to do some kind of ethical check-ins with ourselves as providers to ask ourselves, like, do I have potential biases or values or thought processes that might prevent me from providing the most optimal care to this population? If the answer is yes, we just have to be professional and understand that we're not the best person to be working with that family or youth, and then the ethical thing would be to refer them to the right person. And so it's very okay to say, I'm not comfortable working with this population, but then the due diligence is to get them to the right person. So a little bit about our clinic. I don't know how much you all know, but so we're in Bay Area. We're kind of in what's considered South Bay, which is south of San Francisco, closer to San Jose. So that's kind of our main catchment area is South Bay. But we pull from all over California. We even have many folks from Hawaii who share time in California come to our clinic. During COVID, it was a lot easier because we did do a lot of telehealth across state lines, but now they're cracking back down. And so our services are more limited to California again. But we opened our doors in 2016 by Dr. A, who's the big picture here. You'll meet her either next week or the week after, I can't remember. We are a multidisciplinary team. So we have endocrinology, adolescent medicine. We have nurse practitioners, we have nurses, we have a nutritionist, we have a social worker, and then of course myself, and we also have psychiatry involved in our team as well. And then we have various other disciplines throughout the Stanford system that we pull in when needed, like GYN, urology, plastics, dermatology, and speech pathology. Families can self-refer or are often referred by their pediatrician or therapist. Since 2016, we've served over 700 families, and about 20% of our patient population is Asian Pacific Islander, AAPI. The Bay Area is about 30%, so that's pretty representative of our local demographic here. So orienting you to my terms. So very basically, this is the gender unicorn. I will sometimes use the gender unicorn in my clinical work to kind of like I'm doing with you, just make sure that the language my patient is using is the language that I'm using, and that when we use that word, we're talking about the same thing. Because, oftentimes a youth might use a label and conceptualize it very differently than me. So I'll often use this tool to get on the same page with people. It's also a very useful tool to communicate back to the caregivers about how their child identifies and to break these different constructs down for them. So first and foremost, of course, is gender identity. So gender identity is what I say is how you feel in your head and your heart about who you are. And that has nothing to do with biology necessarily. And so the gender unicorn breaks these things up into several domains. So female, male, or other gender. And youth are free to mark on one of the lines, two of the lines, three of the lines, none of the lines. So they get to mark a little X on, and so it's very inclusive and diverse in the way that people can respond to this assessment tool. And I like that because sometimes it's really hard to categorize or quantify gender because it is such an abstract and nebulous thing at times. And so you kind of want to, if somebody's a dynamic mix of things, for example, you'll be able to see that on this tool. So gender identity is what is in your head and your heart. Sometimes that aligns with your biology and sometimes it does not. In the case of gender diverse youth, it often does not align with the biology or assigned or designated sex at birth. And that is oftentimes where distress and dysphoria comes from. Gender expression, on the other hand, is how you put yourself out in the world or how you show your gender out in the world, what other people can see and or interpret your gender to be. So this might be hair, style, clothing choices, makeup, no makeup, accessories, jewelry, pins pronoun pins that you might wear, just different, or even activities or mannerisms, kind of like how you hold yourself, how you walk, those kinds of things. Parents often confuse gender expression and identity. They are assuming that whatever they see is what's going on the inside. And so something that comes up quite often is caregivers will say, well, ever since they came out to us, we have not seen a change in the expression. Like they are still wearing the same clothes that they used to wear. They haven't wanted to change their hair or wear a bra or do these things. And so to them, that disconnect between the expression and the identity is causing confusion or hesitation because they're wondering about the permanence or the stability or the strength of the internal identity. So this is an important thing to assess in two different domains. So sometimes if I get a gender identity that doesn't match or map on to the expression as much, I'll ask about that. I'll say, so these things are not aligned. Is that what you're comfortable with? Is that affirming to you? Or is there a reason that those things might not match up, right? So sometimes youth will say to me, well, I want to wear these things, or I want to express more, or I want to change my name and pronouns, but I'm scared, or I'm not ready for that, or I'm afraid that I'll be bullied at school because it's not safe at my school, or, you know, I don't have the resources or money to be able to do those things, right? So if those things are not aligned, I want to know why. Sometimes it's just, yeah, they're not aligned and that's who I am, right? Like I'm not a super effeminate girl, I'm not a super masculine guy, or, you know, I'm happy with my style. I think it expresses me, it's comfortable. Some kids are really just like, I just want comfortable clothes. My clothes are not gendered. Like I just want to be comfortable. And so that's a point of education, oftentimes for parents to, or caregivers, for me to be able to communicate why those things are not aligned, and either what we can do to get them more aligned if that's what the youth wants, or explain to them why expression does not equal identity. And then we have assigned sex at birth or designated sex at birth. That's typically based on an assessment done when a child is born on external genitalia or chromosomal or genetic testing. And then sexual orientation. So you might be wondering, like, we all know that those things are totally different. Why are they included on the gender unicorn? They are very separate, but oftentimes parents and caregivers confuse the two. I will often hear, well, why can't they just be gay? Or why can't they, you know, at first they came out as lesbian, but now they identify as female. Like, what's the difference? So sometimes there is some confusion on the caregiver's part around the difference between those two, and why, you know, a youth might want to transition rather than just identify as LGB. And so we now conceptualize attraction in terms of romantic attraction and then also physical attraction, which are two separate things. They can be aligned and be the same, but oftentimes they are not. So we do want to ask about them separately. And then again, this is a nice opportunity to provide that kind of education and information back to caregivers, if a youth is comfortable with all this, right? So if they're not out in all of these ways, then clearly we're not talking to caregivers quite yet about that. Okay, so when I am meeting a family for the first time, the thing, I'm listening for some key things, and I'm sort of clinically categorizing parents into specific types that I've commonly encountered. So we have what I'm calling, I've totally made up these terms, but I'm calling this the worrier. So these are parents that are really focused on their child's future. And thinking about, you know, either their life's going to be so hard if they identify this way, they're going to face discrimination, they're not going to be able to find a romantic partner, they're not going to go to college or get a job, you know, all of these things. Or, you know, they're also worried, or they're worried about medical intervention and what the long-term consequences of those things might be. So potentially that they're going to regret medical transition, or that there will be negative mental health outcomes because of regret from transition down the line. You know, so I have found the general approach to working with the worrier is just kind of normalizing the situation, and also providing lots and lots and lots of information. People who have anxiety, like information can really quell that anxiety. And so I just, you know, answer all their questions as best I can and provide statistics and kind of just say, you know, we've seen a lot of kids like your kid. You know, you only know your kids, so it feels like they're the only one going through this. But we, you know, this whole clinic, we have 700 patients that, you know, feel similarly to you, and we've seen the positive outcomes from this. And so really providing a lot of reassurance is important to these families. Then we have what I'm calling the misinformed. And so these are people who have maybe absorbed incorrect information or taken those as absolute fact. So unfortunately, this is a highly politicized issue and population. And so there's a lot of bias when it comes to your Google searches, right? So if I search risks of hormone therapy, some really scary things are going to come up. But if I Google benefits of hormone therapy, some really different things are going to come up. So a lot of times, depending on how parents are approaching their searches, they're going to be sometimes led down a rabbit hole of misinformation. And so with these families is where I kind of find like research to be really valuable to sort of combat whatever like they've, whatever they've absorbed or read online. And to, highlight how their child is maybe different than the other cases that they've read about or heard about, and how, for example, a lot of parents read articles or narratives from people who detransition later in life. And we want to acknowledge, like, yes, absolutely, like that those narratives exist. I don't want to discount those individual journeys, but those individuals might have gone through transition at a very different time where we knew very different things about this population or how to best approach treatment and assessment and all of that. And so, I want to highlight historically sort of like where that person existed and where their child existed, but also how that person's story and their child's story might differ as well. The wanderer is a caregiver who has really very, very little contact or knowledge about, gender diversity or even the LGBT community at large. And they really have not looked anything up. They really just know nothing. They're kind of like deer in the headlights with all of the terminology and all of the things. And they want to do right by their kid, but they just don't know where to start. And a lot of times families like this need a lot of direction from me. So giving them, I don't like to tell families what they should or should not be doing. I try to be very collaborative and kind of help a family come to an agreement about what they want to do next. But with these families, I do need to be a little bit more directive and be like, you kind of need to trust me on this, and this is what I think would be best, those kinds of things. Just because it's so much for them to absorb, they don't even know how to make a decision for their child. And then we have, unfortunately, the unsupportive parent. So this is someone who maybe has heard the information, has talked with a number of professionals about their child, and still has very strong views for whatever reason that are inconsistent with being able to support their youth. So with these families or caregivers, I really try to understand as much as I can like where that is coming from, like where these strong views developed. Is it, for example, their upbringing? Is it their culture? Is it their faith? Is it they met someone or knew someone? Or is it that their parents are maybe pressuring them to act a certain way or do a certain thing, right? So I really want to understand where that's coming from to be able to address that at the core. And, just this group of parents is probably like the one that requires the most time, effort, work, and patience to work with over time. But if you can really get at the core of understanding where that's coming from, sometimes you can affect change. And then the scientists. So here in the Bay Area, we have a lot of educated people, a lot of scientists, a lot of data-driven individuals. And so I have a lot of families who just come in and say, what is the percent? Like, what are the rates? What, percent of kids have this? What percent of kids have that? How many in your clinic? They need numbers, lots of engineers, lots of computer scientists here. So they need those tangible numbers to be able to make good decisions. And so again, this is another type of family that I would approach with a lot of scientific articles and send them to them directly. So I'm sort of clinically conceptualizing families and caregivers based on these categories that are thematic categories that have come out in my work. But I'm also trying to assess like readiness for change, right? A lot of people assume that once a family is coming to a gender clinic that they are at a certain point of readiness, but that is certainly not the case. We have a lot of families who are coming to us begrudgingly or under duress. Or they had psychiatric hospitalization, for example, and the only way that the youth would safely discharge home is if the parents committed to an appointment with us. And so we certainly get a large range of readiness and support from the families that come to our clinic. And so you kind of have to figure out like where are they and like what at which speed can we affect change, and also like how much time is this going to take and what kind of effort is it going to take. So kind of what I would say is like a pre-contemplative stage, like not ready for transition or change at all, is really caregivers who are in denial about their child's identity. So we have a good number of families who are not using name and pronouns. They will say things like, we know that this is because of XYZ. We know this is because of YouTube. We know this is because of their friend who came out of trans. We know this is because of trauma. We know this is because, they're trying to get attention or fit in, right? And so they're not even entertaining the identity as something that could even possibly be stable. So of course, at this stage, we're going to have a lot more resistance. And so my primary goal with families at this stage is just to keep them engaged, because the fact that they came to us was already difficult. So I just want to keep them coming to us at that point. And so hitting families in the pre-contemplative stage with, really strong recommendations about, your child should transition, you need to use name and pronouns, you need to do this, you need to do that. I have found that really ineffective. I've lost a lot of parents and families to follow up because we came too hard, too fast. And so really during those first appointments, we're just kind of listening to the parents and listening to everybody's kind of story and just saying, hey, we need to open up the lines of communication here because it seems like y'all are not talking to each other about this. And at least everybody can be in agreement that, yeah, we're not talking. That's usually low-hanging fruit that you can say, yeah, okay, so let's work on that. Like, why don't you come back? Well, just open up the lines of communication and start trying to understand each other, right? So that sometimes is enough to get me some buy-in, at least to get them comfortable to keep coming back. At the next stage of readiness, we kind of have caregivers who understand that their child identifies a certain way, and they respect that their child identifies that way, but they maybe don't see any need to change what they're doing, like use name or pronouns or like buy binders or, do anything. They're kind of like, yeah, you do you, and like, we're just going to keep doing what we're doing. So, of course, there's a lot of psychoeducation that I would use at this point of readiness, especially regarding the need for parent support as the major buffer against negative mental health outcomes, which I'll show that study in a second because I use that one quite a bit. And how even though teens act like they don't need their caregivers or parents, like they really do. And especially in this context, they certainly do, right? Next phase of change are caregivers are trying to support their child. Maybe they're using name and pronouns, but they're not like 100% of the time doing it, but they're trying really hard. They're trying to catch themselves and correct themselves. But they have reservations about taking it further. So maybe this, as a family that uses name and pronouns 80% of the time, 90% of the time, and they've let their child transition at school with name and pronouns, and they've bought them the things. They're pretty comfortable doing anything that's reversible. I hear that a lot. I'm comfortable with anything that's reversible, but anything permanent is makes me nervous, or I really feel hesitant about that. So these are families that might just have more reservations about taking the next step. They feel like they're doing enough that, we can hang out here for a while and not keep moving down this road. And then at the higher levels, you know, we have caregivers that are actively coming to us saying, we're ready, we want these things, here are all the letters, here's everything you need. And they're super engaged in the process, and they're like, tell me what I can do, tell me what more I can do, you know, send me to the support groups, tell me about all the meetings, give me all the books, right? And then, of course, at the highest level, you know, it's kind of like fully achieved support in that caregivers are easily using name and pronouns, they're comfortable with the interventions, and they even become, at the highest level, advocates and allies to the community. So I'm really going to be focusing on like these first 3 levels and not the bottom 2 levels, because the bottom 2 levels are a lot easier to work with. And I feel like we need more strategies to help with those more resistant families. So at that first level, the caregivers are denial about the identity. These are things, these are not my made up words. These are words I have heard from families. I warn you that they might be triggering. And some of them are bordering on transphobic or are transphobic. So please know that these are not my words. So it seems like this is just trendy right now. They only identify that way because of YouTube videos I said that one already. Isn't this just social contagion? This wasn't around when I was their age. Why are the numbers increasing so rapidly if it's not social contagion? So my strategies for combating these sorts of comments are providing historical context, because a lot of times it's like, it was there, we were just unaware, or you were unaware. We weren't talking about these individuals and highlighting their stories. And also describe the potential reasons that numbers might be increasing. And then assure caregivers that this is not due to social media, right? Like, I'm sure your child is watching a lot of things on YouTube that are not just about being transgender. Are they adopting or wanting to change in all those other ways? You know, a lot of them are doing silly stunts, you know, or, you know, really dangerous things. Are they doing those things? Right? And so why this and not all those other things that they might be watching on YouTube? So for a historical context, I do like to broaden our cultural scope for families. So understanding that since the beginning of a lot of different cultures around the world, more than 2 genders exist in a lot of cultures. You know, the binary is really quite rare and is really in Western white colonialized societies. And so, yes, that's kind of our primer in the United States, but across the world, that's not always the case. And so this is a map from PBS. So PBS did a Frontline, or I think it was a documentary on like just gender in different cultures and across the world. So this is a cool interactive map. You can click on the little dots and it'll tell you about the gender variation in those different cultures. And so this is really helpful, especially if you have families from other countries that might be on this map. It's really nice sometimes to be able to highlight in your home country, you know, this is a recognized kind of variation of gender that's outside the binary as we conceptualize it, right? So it's nice to just step back culturally and maybe like, okay, like maybe the binary is not the only way of conceptualizing gender, but then also to provide that historical context. So we do have a rich documentation of transgender individuals throughout history. And the history I'm going to highlight here is just in Western white colonialized society. So even in our very binary and structured way of seeing gender, there's still a lot of history going back centuries regarding transgender individuals. So as early as in 1755, Charlotte Clark, who's pictured here, publishes their autobiography, and it's the first permanent document of an open transgender male. So he's pictured here with his wife, actually. And so we have documentation of this as early as that. And then in terms of like medical interaction with this population, so in 1910, Magnus Hirschfeld opened the first clinic to serve transgender individuals, and that was in Berlin. In the United States, 1917, Dr. Alan Hart is the first documented male to transition with surgery. 1930, Lily Elbe, the Danish girl, is based on her life, is the first known recipient of gender-affirming surgery, vaginoplasty. And then in the 1940s, 1948, Harry Benjamin becomes the first endocrinologist to start using hormones to affirm people's gender. And then 1966, we have the first gender clinic at Johns Hopkins in the United States. And then in 1972, Sweden starts allowing citizens to legally change their sex on driver's license and legal documents, right? So we have, this isn't new, right? I know it feels like a lot's been happening in the last 10, 15 years, but the medical kind of support for these individuals has been there a long time. And even the social support of being able to legally change your name has been an option in other countries for a long time. In terms of rates, so the 2016 Williams Institute survey, which was with adults, estimated that about 0.7, I'm gonna round up, 0.7% of the US population identified as trans, and that was noted to be double the amount of 10 years ago. In youth, we see about the same rates. So the Williams Institute did a similar study with youth, and it was 0.7%. However, it's how you ask the question sometimes. So in early surveys, we did not have the knowledge to be able to assess accurately someone's identity. So the question in this Williams Institute survey is, do you consider yourself to be transgender? Transgender is not necessarily an umbrella term for gender diversity or all the kaleidoscope that occurs within gender identity. And so there are many patients that I know of who would say no to that question, but come to us and are on hormones, right? And so it's a very restrictive way of asking about gender diversity. So a Minnesota study that happened more recently of high school students asked a little bit more nuanced. Do you consider yourself to be transgender, genderqueer, gender fluid, or unsure about your gender identity? And that study showed about 2.9%. So, you know, when you're talking about percents of people who identify a certain way, you got to ask yourself, well, what did they ask, right? You know, because if you're more restrictive, the rates are going to be low, but if you're more inclusive, the rates are, of course, going to be higher. Like that just makes logical sense. And then sometimes parents wonder about, is this a US kind of epidemic? No, the rates are similar in other countries. New Zealand did the survey of their high school students and found very similar rates to the Minnesota study. And then, of course, you can't underscore people's safety, right? People feeling as though I can mark yes on this and nothing bad will happen to me, right? I mean, I remember as a half Asian person in high school, taking the SATs, the question on what your race was, I remember thinking, if I put Asian, am I going to get in trouble? Like, are they going to think I'm a liar? Because my last name is Brady. Like, that's not Asian. That's very white. And so are they going to think I'm trying to sneak into college or like get some sort of, you know, advantage if I mark Asian, right? I felt very scared and very uncomfortable that somebody was going to kind of out me and say, like, you're not really Asian. And so I typically would mark white until the check all came into my life. And then I was like, oh, fuck, thank goodness. Like, I don't have to pick one anymore. I can mark both. But, you know, that was a dilemma for me. And that's not even gender. Like that's not something that is as burdensome or heavy as this. And so you can imagine, you know, people 10 years ago marking that at a form would wonder, like, what's the government going to do with this information? Or, you know, who's gonna see this? What's going to happen? Is my address associated with this at all, right? So I think because we're talking about it and it is so much more accepting and inclusive, that people are more likely to be like, yep, that's me, you know, and that's nice that we've come to that place. So are the rates increasing? I would say no, because I feel like it's always been there. It's just people didn't know or have the language to communicate or felt the safety to be able to communicate about who we are, who they were, right? So I find that providing that context to families in that pre-contemplative stage can be very normalizing and just kind of assure them like this isn't, you know, an epidemic that, you know, our kids are facing these days. Okay, so next level, so the caregiver is understanding that their child identifies a certain way, but parents or caregivers don't feel a need to support or change anything. These are the comments I hear from these types of families. My child doesn't seem bothered by pronouns. They say it's okay for me to use their birth name. I've never heard them correct anyone. They haven't asked me to use a different name or pronoun. And nothing has changed since they came out, sort of like I was saying earlier. So with these families, I really try to emphasize the importance of caregiver support as an intervention, and actually it's the most effective intervention we have. Highlight the difference in people's journeys and how hard it is to advocate for oneself in the beginning. How identity and expression don't always align. And then breaking down gender stereotypes, right? So I have a lot of families who say like, yeah, she, you know, my child identifies as female, but they don't want to wear makeup. It's like, well, neither do I. And that's an okay way to be feminine. You know, it's interesting because some families are very open to like, yeah, you know, my child identifies this way, but they're not identifying in that way the right way. Right? Like it's kind of funny how they apply those stereotypes to the affirmed gender. So they're being supportive, but not kind of at the same time. So importance of name and pronouns. So we have a lot of data and evidence suggesting that name and pronouns matter. So this study highlighted that using name and pronouns in one more additional setting could lower depression scores significantly, suicidal ideation in half, and suicidal behavior was lower as well. And that's even when controlling for social support or perceived social support. So increasing by one context reduced depression scores by 5, 29% decrease in SI, and 56% decrease in suicidal behavior. So I always tell parents who are struggling with name and pronouns, you love your child. Like, I know you want to do what's best for your child. The most effective intervention we have is for you to use the name and pronouns. If you do that, like they're already usually getting it from their friends. So by you doing it, that's adding this extra setting. And by doing that, you are going to improve their mental health significantly. I will also tell families that it takes this issue off the table, because I will tell you that if a family is not using name and pronouns, that is all a patient will talk about in their therapy. And we do not have time or space to talk about anything else, because that is the number one thing that is distressing them, that their parents are still misgendering them. They still don't get it. They still make these comments, right? So when parents do this, it opens up so much space in the therapeutic like space to be able to talk about other things. So I will tell parents, like, we're not really, you know, making the progress that you want us to be in therapy because the fixation is on you. And that's external. And I need it to be internal, right? I need them to be doing this internal like processing and exploring. But there's so much external stuff going on that's getting in the way. So sometimes that explanation gets the buy-in that I need to be like, oh, okay, like, you know, I guess we'll just do it, right? I also just say, like, you know, if parents tell a kid not to do something, like that, sometimes that rebellious nature just makes them want to do it even more. So I'm kind of like, if you just do this for them, like whatever they decide will be more based on them and less about your refusal.
Dr. Brady, a question, please?
Yes.
So you would advise parents to ask their child what their pronouns are?
I would.
Thank you. I wanted to get clear on that.
Yes.
For everyone.
Yeah, you know, just because a child has not shared, you know, their name and pronoun doesn't mean they don't have one. And parents, and in the beginning, like I said, it's hard for a youth to put that out there and advocate for themselves and ask for that, because that's a big ask for a lot of my patients. And so, you know, the onus should be on us as the adults to take some of that pressure off and say, hey, are you using any name and pronoun? Like, you know, it allows the youth to be like, actually, yes. And it makes the conversation so much easier if the parent brings it up. 100%.
And we have one more question.
Oh yeah, thanks for monitoring chat for me.
Oh, I fell behind. That's why that's why Dr. Cohn stepped in. Dr. Weir says, how does your clinic handle chart and billing information in patients who identify with other than their birth biologic identity?
So we use Epic here at the hospital, and we have worked with our Epic team to add in additional fields. It's called the SOGI, Sexual Orientation and Gender Identity. And so there we are able to break down designated sex and gender identity, and we're even able to say what the preferred pronouns are. And so that pops up, like when you bring up a patient's chart, it's right there, right by their birthday. It says what their pronouns are. You can also put the name. Unfortunately, we cannot expunge the legal name completely from medical charts because it has to match whatever's on the insurance for billing purposes. And unfortunately, that causes a lot of distress for my patients because they will get bills with their name, their prescription, their hormone prescription has their name on it, so their appointment reminders still, have the name on it. So it's not a perfect system, but at least there are ways to alert our nurses, the front desk, about the name and pronouns. So at least when they're interacting with a live person here, everybody is using name and pronouns correctly.
Thanks. And then I just want to mention that Dr. Weir says he routinely answers the race question with human.
Yes. Yes, like other human. Love it. Yeah, so I always kind of, let parents know that just because it doesn't look like something's happening doesn't mean it's not happening, right? So a lot of times dysphoria is not being expressed or is not visible to outsiders. And so just because it doesn't appear to matter doesn't mean it doesn't matter. So if your child has not asked, that doesn't mean there isn't something going on or something that they want. Again, I do want to empower my patients over time to be able to advocate for themselves, but that's going to take a lot of time, a lot of confidence building, and a lot of strength and courage. And so I don't expect that overnight. And so we do, as the adults, need to step in and kind of be the proxy for that until that comes online for themselves. Again, going back to the gender unicorn. So if a parent is struggling to understand how this all comes together and what the differences are, then, I'll use this assessment tool. For caregivers who are trying to support their child but have reservations regarding an intervention, these are the comments we might hear. Why can't they just identify or be male or female or other without changing their body? They're too young to know what they want. We don't know enough about the medical risks. So, of course, with these families, I want to help youth verbalize and communicate their internal experience to their caregivers, because typically caregivers are cisgender, and so they have not experienced gender dysphoria. And so that's a very alien kind of concept to them. And it really helps I can explain it to them on the child's behalf all day long, but at the end of the day, I think it needs to come from youth a lot of the time. And so I will help them find those words or ways to communicate dysphoria to their parents, and also communicate how XYZ intervention will meet their goals and alleviate their struggles or their dysphoria in certain ways, right? Because parents need to know that, like, my problems, this intervention, like those things match, and that this is going to help me achieve and thrive and get to where I want to be. I provide education about just gender development, not even within the transgender space, but gender development in children, because it occurs very early. And then I encourage families to speak with our medical team or medical professionals about their questions about the risks and things like that, because again, information is what a lot of these families need. So in terms of just basic gender identity development, like there have been, this is Kohlberg's model in 1966, unfortunately is very binary, but it still holds true today in terms of when kids start to think about these kinds of things. So Kohlberg observed and proposed that basic gender identity is formed at ages 2 or 3. And we know this to be true because we know trans kids who come out as soon as they can verbalize girl or boy or, something else. They are very much able to identify that early, and it does happen. And we have seen very stable identity across into adulthood from those kids, right? So we know that this can occur early on. Around age 4 or 5, kids start to understand what he called gender stability. They understand that, if I'm a boy today, then I'll wake up a boy tomorrow. It's not just going to spontaneously change for me. I know what my identity is, but I now understand that that's going to continue throughout the rest of my life. And then they develop gender consistency around age 6 or 7. And then in that, they understand that changing expression is not going to change the identity. So if they have a desire, so they understand what their gender is, they understand that that's going to be consistent over time. If they feel like that's not what they want, and they want to be something different, at age 6 or 7, they realize there's really nothing they can do to change their gender or biological sex. And so oftentimes, we'll see dysphoria in all of these stages, as well as the later kind of onset kids where it develops at puberty, because, the body is changing in significant ways that are no longer consistent with how they identify. And I'm sure Dr. A will talk more about her medical kind of piece, but this is just a snapshot from the WPATH standards of care about the medical risks. And I like this because it categorizes it as no risk. These things are in the mythos of risks, but they're not actually observed risks, to possible risks, to possible increased risk. So it kind of categorizes how likely the different medical sequelae and risks are. So these are a couple of studies that also highlight the psychological benefit of medical transition for use, so blockers, hormones, and surgery. So this is just kind of snapshots of those. I, again, will share these with families if I feel like they are helpful. I'll ask families, do you want the actual scientific article, or would you like a summary of the article and the data? Because depending on, just the literacy and scientific consumership of the families, they may or may not be able to read the statistics and understand them. So I'll kind of say, which format do you want? So overall, I really try to meet caregivers where they are and approach in a collaborative manner. I use that trauma-informed kind of mindset to get past any frustrations I might be having, but, try to take a deep breath and say truly understand where this family is, why they are where they are, and how I could potentially even sometimes glacially move them forward. Because I have found that if I don't meet them where they are, that will kind of turn them off or not have them come back. And I do want them to keep coming back. I express understanding, and emphasize often that they do care about their child and that, you want what's best for them and all of that, because sometimes caregivers are on the defensive about that. I build a lot of rapport. Takes a lot of patience before challenging. So if I get that relationship, I get the buy-in, and I get their trust, they're more willing to listen to what I have to say, especially if they feel like I really understand their child, right? So I can't just meet and greet their child for 20 minutes and then tell them what to do, because they're not going to think that I know everything I need to know about their kid, right? So I've got to spend time really understanding each individual patient and family dynamics. Often refer to parent groups or parent mentors. So here at Stanford, we're lucky enough to have 2 parents that work in our clinic who were former patients. Well, their children were former patients of ours, but they're now adults and in college and things like that. So they can talk with our new parents about their journey and kind of remember the anxieties of where parents were at the beginning. And they can also share their positive outcomes down the road and how their child is thriving. And those stories are important to hear as well. Parent groups can also really help hear from other parents about what they're struggling with and how they got past certain things. And again, be patient. There's some families I work with very briefly, and then there's parents I've been working with for a year and a half that have still made very little movements. And I'm not giving up. And I tell my patients that, like, look, I know it seems hopeless, but like, I'm holding the hope for you. I'm not giving up. Sometimes it's just wearing them down. Like, you come at them, you can have the same conversation over and over and over again. And then finally they're like, oh, fine. And sometimes that's just what it takes is persistence. And you won't always win. So that is a heavy burden that I carry. There are families who, and kids I think about that are struggling and suffering. And we tried everything we could, and we just couldn't get that family to move. And that's just a reality. And in those cases, I just try to help kids survive until they're adults. And I try to encourage them, empower them to be independent, to get a job, to get a license. So they do not have to rely on their caregivers once they turn to adults. So happy to pause here, answer questions. I do have cases if you all are interested in that, or we can just chat because I talked more than I wanted to. Shoot.
Well, it was very interesting. So that was perfect. Are there any other questions? And nobody came up with a case, but if you have one, just let me know. Or even just a question case.
Yeah.
I had a patient who said this. What should I have done? Nobody.